and then we'll go from there. So, Dr. Fleming, do you want to talk about your experience with some of the treatment protocols that you've designed and the difficulties you've had in getting them out and the pushback you've received from the establishment?
Right. Well, first off, thank you for inviting me to be here, and for everybody who's agreed to appear here today. I think it's important for us to each give this type of information to the general public, because this is the best opportunity that the general public has to hear truth and some transparency about what's really going on in medicine and COVID-19. You know, when I entered medical school, the second thing the dean of our medical school told us was that 90% of what we were going to be taught was wrong, but they didn't know what that was. And they encouraged those of us who were research oriented to step forward and to do that type of research to make the field better. Because I was already a physicist to begin with when I came in, I took that challenge literally. What he didn't tell us was how much resistance there would really be to changing the system, which I've had a wonderful opportunity to learn about on firsthand basis. I don't think I would change what I've done, despite all the blowback and the problems that have occurred, because what I did was I held true to my Geneva Oath, which is similar to the Hippocratic Oath, but our class decided to take the Geneva Oath, which evolved after World War II, after watching Nazi Germany and making decisions about not to treat patients like they had been. It was discussed in the Nuremberg trials. When I was in medical school, part of what I became actively involved with was heart disease. I joined the American Heart Association in 1976 as the youngest person in those affiliate faculty positions. And I helped to rewrite the guidelines for cholesterol and ACLS and a number of other things. But by the time I was in my cardiology fellowship, so for the listener, you have medical school, internship, residency, and if you're dumb enough, you try to get into a fellowship position. If you're really stupid, then you become a nuclear cardiologist and add even more time on it to that. And my involvement and work there looked at the effects of diets and heart disease, and I was one of the people that was actively involved in doing the Dean Ornish patients way back when. And I looked at blood flow, and I was asked to look at some of the newer isotopes that were coming out to be looking for heart disease. And so I wrote some of the first papers on those. And like everybody at that point in time, I went along with the party line, which was that you needed 2 doses of radioactive isotope to do these studies. And you had to wait an hour before you start imaging, and then another 4 hours to do the second image. And when I got out of my fellowship and had my own private practice, that's when I began to critically look at that. And I discovered that, lo and behold, you didn't need to give 2 doses of radiation to people. You needed to only give 1. And that if you started imaging very early at about 5 minutes versus waiting for an hour, you would find critically ill patients that you otherwise would miss. Big Pharma was not really excited about that. That's led to my legal issues that I ended up with in court, where I was accused of actually committing billing fraud because I got 2 sets of images after giving only a single dose of radioactive isotope. Turns out that now most people in the field accept that you only need the 1, that this isotope does move around. And there's been other people like Cedars-Sinai and Emory and lots of other places that have shown these images, but you have to move right away to do it. Big Pharma wasn't happy about that, because essentially what that means is that the 3 million extra curies of radiation that have been delivered to people never needed to do that. That is the equivalent of 1/3 of the radiation that shut down the Japanese reactor. You did not need to waste people's times by extending it out 4 hours versus 1 hour. You found the critically ill people by doing it the way that I had recommended. And currently about 100,000 a year critically ill people are missed using the current approach, and they end up dying from critical heart disease. And Big Pharma really is not very pleased with the fact that that means that they've essentially billed $20 billion of extra billings in the last 2 decades. And we've paid for that as taxpayers from CMS and all the other health insurances. That court case was the most interesting experience I've ever had, because it showed me how evidence is hidden in trials, how judges will work with the attorneys to hide evidence. I've got a very nice tape where the judge is talking to the attorneys where he says the jury doesn't need to know the whole truth and the wool can be pulled over their eyes. It's very enlightening when you get it. It's not very fun to go through, as a lot of people have experienced. But the reality is that my commitment as a physician is to the patient. It's not to the courts. It's not to the politicians. It's not to the journalists. It is to the patients, and it's to my peers, and it's to my peers in medicine and to my peers in science. And so that commitment I've held true to, and part of the most recent thing that I have done is as a result of understanding all of that and understanding the errors in that testing, is I've developed a patented test called FMTVDM that allows us to measure changes in tissue as they're occurring, allowing us to see things earlier in the process. And between that and the inflammation theory that I developed in 1994, I know Judy is familiar with this. In 94, I came up with a theory that says it's not cholesterol that causes heart disease, although cholesterol is involved. It is an inflammatory process. So I presented that in 1994 at American Heart meetings, laying out all the details. I did it again in 95. In 1999, I published it in a cardiology textbook. In 2000 and 2002, I published papers looking at bacterial infections and how the thymus gland became prominent, how T cells got activated, how when we treated the infection, we successfully reversed some of the heart disease. The thymus gland attenuated back, so we showed the role of bacteria and viruses in that. And then in 2004, I was on 2020. And so I think probably the thing that I find most disheartening with COVID-19 is that despite having presented this theory 26 years ago, and despite people having published how to correctly use ventilators 15 to 20 years ago in that little known journal, New England Journal of Medicine, the people that have been taking care of COVID patients have not been addressing the reason why they're dying, which is an inflammatory thrombotic process. They have been chasing a virus, and while I recognize this isn't maybe where we're at yet in the conversation, I'm actually calling at this point in time for people to recognize that we first off have not been treating this correctly, that we need to treat the inflammatory and thrombotic consequence. That's why there's hundreds of thousands of people who are dead. And that PCR testing, routines testing in society outside of a hospital or doctor's office, where the physician knows whether they need to be initiated on treatments like hydroxychloroquine, zinc, and azithromycin, which if we get to it, it's not just a secondary bacterial prevention, it actually prevents the replication of the virus. That at this point in time, I'm actually calling out for a moratorium on PCR testing in settings other than a doctor's office or hospital. I'm aware of nobody who's been denied access to a hospital because they didn't already have a PCR swab in their hands. And testing people for PCR outside of the hospital, even if it is correct, which we can argue about, does not provide them the treatment that they need. And those subsequent days are critically lost days that these patients are not being treated. Next.